بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على رسول الله وآله وصحبه أجمعين. Today inshallah we'll continue with the anatomy of the gastrointestinal tract, and this is the last lecture which deals with the lower gastrointestinal tract. I just want to remind you before we start the lecture, the slides number 3 and 6, these are slides which remained from the last lecture, or the first lecture, which was on the upper gastrointestinal tract, and the remaining slides belong to the lower gastrointestinal tract. The objectives of today's lecture is to cover the relevant anatomy of the large intestine, including the rectum and anal canal, and try to differentiate between the different parts of the large intestine. And then, as we did basically with the other lectures, so we'll cover the important relations, blood supply, lymphatic drainage, nerve supply, and also some clinical or applied anatomy related to the large intestine. I'll start with the remaining slides from the lecture of the upper gastrointestinal tract. So we stopped at the end of the duodenum, and today we should continue with the remaining parts of the small intestine, and which are the jejunum and the ileum. So the jejunum and the ileum are these parts of small intestine, and the two parts are so collectively they are 6 meters long. The jejunum makes about 2/5 of these 6 meters, and the 3/5 are made by the ileum. So ileum is longer than the jejunum. The second thing you need to know about these two structures, that they are intraperitoneal. So the duodenum was mostly retroperitoneal. The jejunum and ileum are intraperitoneal, which means they are covered by visceral peritoneum, and they also have a mesentery. So this is the mesentery of the small intestine, which attach the small intestine to the posterior abdominal wall, and in the mesentery there will be the blood vessels, the nerves, and the lymphatics, which should reach the small intestine, and also some fat. So this is the mesentery of the small intestine, and the place of attachment of the mesentery of small intestine to the posterior abdominal wall is called the root of mesentery, and it is this one. So if you see this line, so that's the line which corresponds to the attachment of the mesentery of the small intestine to the posterior abdominal wall, and we call it the root of mesentery of small intestine. So it starts from this point, which is at the jejunal junction, the junction of the duodenum and the jejunum, and then it continues obliquely towards the right side and ends at the junction between the ileum and the cecum. So it's an oblique line which starts at the left side of lumbar vertebra number 2 and ends adjacent to the right sacroiliac joint. And as you can see, it crosses certain structures on the posterior abdominal wall. Among these structures are the superior mesenteric artery, superior mesenteric vein, abdominal aorta, and this muscle, the psoas major muscle, and this structure, which is the right ureter. So these are structures crossed by the root of small intestine. Now we have jejunum and ileum, and I already covered this in last week's practical, how to differentiate between the ileum and the jejunum. Now you have on this image you have the two structures. This is the jejunum on the left side, and that's the ilium on the right side. So there are certain differences between these two structures in terms of some features. Now if you look at the jejunum, it's bigger, so it has a wider lumen and a thicker wall, and it's more vascular. That's why it looks more reddish. So it has a wider lumen, a thicker wall, and more vascular. So this is the jejunum. Ilium on the other side, it has a narrower lumen, a thinner wall, and it is less vascular. The other differences between these two structures is the arrangement of the blood vessels in the mesentery. And so there are loops of blood vessels that we call them arcades, and then from these arcades there are branching long or straight blood vessels that we call them vasa recta. So the jejunum has fewer arcades and longer vasa recta, while the ilium has more arcades. So you can count how many loops. So 1, 2, 3, 4, 5, and sometimes more. So the ilium has more arcades but shorter vasa recta. There is also a difference in the fat, amount of fat found on these structures. The ilium has more fat. So fat in the mesentery of the ilium is more than the fat in the mesentery of the jejunum. If you look inside, so this is an inside view, and then there is a differences also in the amount of plica circularis. The jejunum has more plica circularis, or we call them the circular mucosal folds, which we call them the plica circularis. So they are tall, more and closely packed in the jejunum, while in the ilium they are smaller and widely separated. So the inside wall of the ilium looks smoother than the inside wall of the jejunum. Now you also need to know that the differences between the ilium and jejunum, it's gradual. So there is no one point where you can tell that this is the end of jejunum and that's the beginning of ilium. So the change is gradual between the jejunum and ilium. The other difference is the presence of lymphoid aggregations in the wall of the ilium that we call them Peyer's patches, while they are not found in the wall of the jejunum. So Peyer's patches are found in the ilium but not in the jejunum. Now you can also put where you find these two structures mostly in the abdominal cavity. So the jejunum is usually in the around the umbilical region, while the ilium is much lower in the hypogastric region, and it extends, its loops also extend into the pelvic cavity. So these are the differences between ilium and jejunum in terms of these features. The blood supply of ilium and jejunum. Now blood supply of, now you should know by now that ilium and jejunum, they both belong to the midgut. So they should be supplied by the superior mesenteric artery. So that's the superior mesenteric artery, and then which supplies the jejunum and ilium. So it has jejunal branches and ilial branches. So jejunal arteries and ilial arteries branching from the superior mesenteric artery. So and towards the end of ilium, so there is this artery that will supply both the end of ilium and also the beginning of the colon, and this artery is called ileocolic artery. So we have jejunal arteries, ilial arteries that only supply either jejunum or the ilium,
but the ileocolic artery supplies towards the end of the ileum and beginning of the colon. That's why we call it ileocolic artery. If the veins are just corresponding veins, so we have jejunal veins, ileal veins, and ileocolic veins, and eventually all of them will drain into the superior mesenteric vein. Lymphatics, then you should think of the arteries. So all the lymphatics eventually from the ileum and from the jejunum and ileum will follow the arteries, and they will end up in the superior mesenteric lymph nodes. Likewise, nerve supply comes from the plexus of nerves around the superior mesenteric artery, and that plexus we call it superior mesenteric plexus, and that includes both. So this is an autonomic, and it should include sympathetic and parasympathetic. Parasympathetic is from vagus, sympathetic is from the sympathetic chain at the level of T9 to T12. Now, as we did with the stomach, now you also should think of referred pain. So, and referred pain usually follows or runs with the sympathetic. So the sympathetic supplies comes from T9 to T11. So referred pain should be referred to the T9 and T11 dermatomes on the anterior abdominal wall. And now you should know that at the level of the umbilicus, that's the T10 dermatome, and above it T9 and below it T11. So this is the area where the pain from the small intestine will be referred, and this corresponds with the umbilical region on the anterior abdominal wall. So again, stomach is in the hypogastric, small intestine is referred to the umbilical region, and large intestine should be lower than this, and it should be in the hypogastric region. So again, on this image you have the referred pain from stomach, from small intestine, from stomach, from small intestine, and from large intestine. So this ends the slides that belong to the upper gastrointestinal tract lecture. Now, in the next slide, we should move to the lower gastrointestinal tract. So this is the image of the gastrointestinal tract. So we started with the esophagus in the first lecture and moved to the stomach, to the duodenum, to the jejunum, and ended with the ileum. Now we should continue from this part. Now from this point on, this is the large intestine, and the parts of the large intestine include the cecum, the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and anal canal. Part of these structures found in the abdominal cavity, some will be found in the pelvic cavity, and the anal canal is found in the perineum. So you find parts in different regions of the body. That's why when you refer to your textbook, you will not see these parts in one chapter, but you will see them in the corresponding region chapter. The main differences between large and small intestine. Now, these are the features of the large intestine, 3 cardinal or classic features of the large intestine. I already covered this in the lab video. So those are the 3 parts. First of all is this longitudinal smooth muscle that we call tinea coli. So that's tinea coli is one feature. The second feature is these appendix of fat, so we call them omental appendices or epiploic appendices or epiploic appendages. You find them in large intestine, you don't find them in small intestine. And the third feature are these haustria, these bulging of the wall. We call them the
haustria or the haustriations. Now these are the three external features. Internally, you will find the semilunar folds in the inside wall of the large intestine. So these are the three features. And again, why do we have tinea coli? This is a transverse section of the large intestine where you see the circular smooth muscle. Now this is the inner circular smooth muscle, which forms like a band, while the longitudinal smooth muscle, all the fibers will collect in three locations, and those three locations are the tinea coli. So tinea coli are the places or the three locations where all the fibers of the longitudinal layer of smooth muscle collect. One thing also to note, that these bulging of the wall that called haustria, they are formed because the length of the colon is shorter than the length of the tinea coli. Tinea coli is much longer, and that's why for the tinea coli to accommodate the whole length of the colon, now the colon has to be shortened a little bit, compressed a little bit, and that's why these bulging will appear. One thing that I missed that belongs also to the large intestine is this appendix. So it's an appendix of the large intestine attached specifically to the cecum. Now let's move to the relations. What are the anterior and posterior relations of these parts of the large intestine? Now these are the lengths before we start with the relations. So if we start with the cecum is about 6 centimeters long, ascending colon is about 13 centimeters long, transverse colon is about 15 centimeters long, descending colon is the longest, and it's about 25 centimeters long, and the sigmoid, which you don't see over there, is also 25 centimeters long. Now what are the, you also need to know about these structures. You should know what is intraperitoneal and what is extraperitoneal. So which parts of these parts is intraperitoneal and which of these parts is extra or retroperitoneal. Now the intraperitoneal structures include the cecum, the transverse colon, and the sigmoid colon. So these are intraperitoneal, and if they are intraperitoneal, they should have mesentery, but the cecum does not have a mesentery, although it's an intraperitoneal structure, but there is no mesentery. Transverse colon has a mesentery, and we call it transverse mesocolon. Sigmoid colon has a mesentery, and we call it sigmoid mesocolon. Ascending colon, descending colon, and rectum, they are retroperitoneal, but the rectum, there is a different arrangement, but big part of the rectum is retroperitoneal. We'll see the details when we come to the rectum. So the retroperitoneal structures include the ascending and the descending colon, while the intraperitoneal include cecum, transverse colon, and sigmoid colon. Now what are the posterior relations? This is the cecum. You find it in the right iliac fossa. It's intraperitoneal, has no mesentery, and these are the structures related to it posteriorly. One is this muscle, and that muscle is the iliacus. There is another muscle, and that muscle is the psoas major. There are two nerves posterior to the cecum, and those are the lateral cutaneous nerve of the thigh and the femoral nerve. And also one of the posterior relations of the cecum is the iliac crest. So those are the posterior relations of the cecum. Now if we move to the ascending colon, these are the posterior relations. So this includes this muscle, which is the
quadratus lumborum, and that muscle which is the transversus abdominis. There are nerves posterior to the ascending colon, and those nerves are the iliohypogastric nerve and the ilioinguinal nerve. The lower pole of the kidney also related to the end of the ascending colon posteriorly. Now let's compare it with the descending colon. Descending colon is also retroperitoneal, but it is much longer than the ascending colon. So it starts there at the left colic flexure and descends down retroperitoneally until it continues with the sigmoid colon close to the pelvic brim. So that's the pelvic brim. So the descending colon is much longer than the ascending colon, and that's why usually on the right side, the posterior relations which are shared by the cecum and the ascending colon, now they are related to the descending colon again, and you can list the same structures again. So iliacus, and this muscle which is psoas major, and the nerves including the femoral nerve, lateral cutaneous nerve of the thigh, inguinal nerve, iliohypogastric nerve, and the subcostal nerve and subcostal artery. And you also put the muscles which correspond posteriorly to the transverse to the ascending colon, and these muscles are the quadratus lumborum and transversus abdominis. So this is a very good image to show you the posterior relations of the cecum, ascending colon, and the descending colon. If we come to the transverse colon, these are the posterior relations of the transverse colon, including the second part of the duodenum, the head of the pancreas, and if you go more laterally, then it will be related to the left kidney. Now there is a question also in this image: what are the differences between right and left colic flexures? So this is the right colic flexure where the ascending colon and the transverse colon meet, and this is the left colic flexure where the transverse colon and the descending colon meet. So there are basically three differences. Now focus on the left colic flexure. It is more superior than the right one. So the left is more superior and it is more acute. So the angle or the turn is more acute than the on the right. On the right it's more like a right angle, but on the left it's more acute. And the third is the presence of the phrenico-colic ligament. I already covered this ligament when I talked about the spleen. So these three structures, or these three differences between the left and right colic flexures. So the left is more superior, more acute, and it is attached to the diaphragm by the phrenico-colic ligament. Now what are the anterior relations of the colon? This is an anterior view. The greater omentum has been reflected, and now you can see what you find anterior to the cecum, ascending colon and descending colon, and you don't see in this image what is anterior to the transverse colon, but mostly the anterior relations are the greater omentum. Now it's reflected. When it turns back, it will be anterior to the ascending colon, anterior to the descending colon. And also you can also put the loops of the small intestine. Usually they are anterior to the ascending and descending colon and the cecum. And if this anterior abdominal wall is put back, so it will be also one of the anterior relations of the colon. So again, the three anterior relations are the greater omentum,
the loops of small intestine, and the anterior abdominal wall. If you want to talk more about the transverse colon, now you can also put the stomach anteriorly, because it's it forms part of the stomach bed, and this is from the first lecture. Now let's talk more about the certain parts, just focus on certain features related to some parts of the large intestine. If we start with the cecum, so I already mentioned it, where you find it, what are the anterior and posterior relations. Now we just need to focus a little bit on this area, which is where the ileum joins the cecum. So that's we call it ileocecal junction, and it opens over there, and that is the ileocecal orifice. So that's the orifice of the ileum, where it opens into the cecum. So it has a valve, like a mucosal fold that looks like a valve that prevents materials to go back into the ileum, and this valve is called ileocecal valve. It has the frenulum, which is the fold of mucosa which is guarding that valve. One thing also to note about the cecum, that the appendix is attached to it, and that's the orifice of the appendix, and the orifice of the appendix is about 25 centimeters inferior to the ileal orifice. So it's below it on the posterior or posteromedial. Sorry. One thing also to note about the appendix, that it has no Taenia coli. So there is no Taenia coli in the appendix, and just also to add, there is no Taenia coli in the rectum. So I think I should have mentioned this in the earlier slides. Taenia coli is found in most parts of the large intestine, with the exception of appendix and rectum. So there is no Taenia coli. It's intraperitoneal, covered by the visceral peritoneum. If it's intraperitoneal, it should have a mesentery, and the mesentery of the appendix is called mesoappendix. It has an artery, we call it appendicular artery, which is one of the branches coming from the ileocolic artery. So ileocolic will supply ileum towards the cecum, and one of the branches goes down to the appendix, running into the mesoappendix, and that artery is called the appendicular artery, or the artery to the appendix. One thing also to note about the appendix, that although the base of the appendix, where it's attached to the cecum, is almost fixed, the tip of the appendix can have different positions. So these are the different positions of the appendix. So it can be directed towards different directions. Now, and each direction is having a name. For example, retrocecal, so this is behind the cecum. This is the most common position. So in 64% of people, the appendix is retrocecal, which is behind the appendix. The second most position is the pelvic. So it's pointing infero-medially towards the pelvic cavity, and that's why it's called the pelvic position. And this is about in 32% of people. So these are the two most common positions. The other position include, for example, paracecal, on the side of the cecum, and the other one is subcecal, so below the cecum, and it can also be related to the ilium, either anterior to the ilium, to the end of ilium, we call it preilial. If it's posterior to the end of ilium, we call it post-ilial. And if it's pointing straight horizontally, medially towards the sacral promontory, and now you should know what is sacral promontory from ITA, so we call it promontoric position. So these are the different positions of the appendix, and the tip of the appendix in different people, and surgeons when they remove the appendix during appendicectomy, they should be aware of these different positions of the appendix. Now, although appendix is a small part of the intestine, but it can cause problems to the individuals. So it can be inflamed, and that condition is called appendicitis. So it's one of the causes of acute abdomen. So a condition called acute abdomen, which is severe acute abdominal pain rising suddenly. So it's a sudden severe abdominal pain. Now, why does the inflammation or infection of the appendix leading to inflammation happen? What are the predisposing morphological or structural or anatomical factors that makes this a common complaint? I'm sure each of you will do appendicectomy after graduation. So appendix is long, but it's narrow and blind-ended. So it's blind-ended means it's not an open tube where it joins two other spaces. It's blind-ended and narrow. This makes it gives us the tendency to be blocked by hard intestinal contents. So this is when it becomes infected in adults. So mostly it's hard intestinal contents go inside and they get stuck. The wall also contains a lot of lymphoid tissue. You will do the histology of the appendix when you do the elementary system course. So it has a lymphoid tissue, and this lymphoid tissue, so there is a lot of immune reaction happening, which can lead to infection and inflammation. So there are predisposing factors that make appendicitis commonly occurs. Now, the pain, if there is pain in the or if there is appendicitis, where the pain will be located? First, it starts at the vague pain, which is vague means it's less localized pain in the periumbilical region. So it starts like this, and this is referred pain, usually to the T10 dermatome. And now you know that dermatome T10 is around the or T10 dermatome is around the umbilicus, so pain will be referred to this area, and because it's referred, so it's vague. Later, when the inflammation involves the parietal peritoneum, now the pain becomes somatic pain, and usually somatic pain is more localized, and the pain will shift to this area in the right iliac fossa, and this pain is somatic. First it's referred, then it becomes somatic and shifts and becomes precisely localized in the right iliac fossa where the appendix is found. Now, the maximum tenderness or the maximum pain is at a specific point, a point that is called McBurney's point, and that's where that's a surface marking of the base of the appendix. Now, in the previous slide I told you the base of the appendix is almost fixed, while the tip can vary depending on the position. So the base is always fixed, and the surface marking is a point that is called McBurney's point. So this is the site of maximum pain, maximum tenderness, and how to locate this McBurney's point is you just need to draw a line between the anterior superior iliac spine and the umbilicus, and then divide this distance into 3/3. So this is the 1/3, the 2/3, and the point exactly is where the lower third meets the middle third. So that point demarcates the McBurney's point, which is the surface marking of the base of the appendix. The appendix, if the infection is not treated, it can lead to perforation. Perforation is a big problem, so blood, intestinal content can lead into the peritoneal cavity and leads to peritonitis. So this is a very important case which needs the knowledge of the applied anatomy of the appendix. Now let's move to the sigmoid colon. So I told you sigmoid colon, it starts, or it's a continuation of the descending colon very close to the pelvic brim. So this is the pelvic brim. So this circle corresponds to the pelvic brim. So it starts from there and goes down till and continues with the rectum at the level of the third sacral vertebra. So the rectum starts at the level of S3. So, and that's why the sigmoid colon starts from the close to the pelvic brim and continues to the S3 vertebra. It's intraperitoneal, and it has a mesentery that we call the sigmoid mesocolon, and the sigmoid mesocolon has a root also. Now I already mentioned the root of the small intestine in the beginning of the lecture. Now there is also an attachment of the mesentery of the sigmoid colon that we call the sigmoid mesocolon, and this is where the attachment is, that line. So it's this site, we call it the root of sigmoid colon, and it looks like an inverted V shape. So this red line, so it's attached over there, inverted V shape. So this is a small distance, but the sigmoid colon can be 25 to 28 centimeters, and that's why it will be coiled a little bit like the ileum and jejunum. So it will be coiled because the root is much shorter than the length of the sigmoid colon itself. Now, what are the relations of the sigmoid colon? These are two images from your textbook showing the sigmoid colon in the male and the sigmoid colon in the female. Now, talking about the posterior relations, they are the same whether it's a male or female, it's the same. So usually it's the rectum and the sacrum in the male, rectum and the sacrum in the female. The difference comes in part of the anterior relations. So it's not the whole anterior relations, but part of the anterior relations. Now, whether it's a male or female, you will see the loops of ileum anterior to the sigmoid in the male and in the female, because when I talked in the slide about the ileum and the differences between ileum and jejunum, I mentioned that ileum also can be found in the pelvic cavity. Now you find the coils of ileum anterior to the sigmoid colon in male and in female. The difference between male and female comes with relations to the other structures. So in the male, it's the urinary bladder. In the female, it's the uterus and the upper part of the vagina, mostly the posterior fornix. So these are the
anterior relations in the female, and these are the anterior relations in the male. S3 corresponds to the end of sigmoid colon and beginning of the rectum, so that's rectum. Blood supply of the colon. Now today we cover these parts: cecum, appendix, ascending colon, transverse colon, descending colon, and sigmoid colon. So far we will cover the rectum very shortly. Now as you can see, parts of the colon belong to the foregut, and that includes the cecum, appendix, ascending colon, and 2/3 of transverse colon. So these parts will be supplied by branches from the superior mesenteric artery. The other part, which includes the last third of transverse colon, descending colon, sigmoid colon, and rectum, these are supplied by branches of the artery of the hindgut, and that's the inferior mesenteric artery. So superior mesenteric artery and inferior mesenteric artery, and as you can see there is anastomosis between the branches of the inferior mesenteric artery and superior mesenteric artery. And then if you want to go into more details, now these for example, the superior mesenteric artery will give the ileocolic artery, which already mentioned when I talked about the ileum and cecum and the appendix. And then there is a branch that moves to the right, we call it right colic, and then there is a branch will supply the middle part, we call it middle colic artery. If you go to the inferior mesenteric, so there is an artery that goes to the left side, we call it left colic artery. There are arteries that will supply the sigmoid, we call them sigmoidal arteries, and there is an artery that goes to the superior third of the rectum that we call the superior rectal artery. So again, superior mesenteric artery, inferior mesenteric artery, and those branches. Veins, they are just the corresponding veins. So the parts which receive blood from superior mesenteric artery will be drained by the superior mesenteric vein. The parts which are supplied by the inferior mesenteric artery will be drained by the inferior mesenteric vein. And then you can revise the formation of the portal vein, which is formed by the superior with the splenic vein and the superior mesenteric vein, and you can also see the inferior mesenteric vein will drain into the splenic vein. Lymphatic drainage, again think about arteries. So the parts which are supplied by the superior mesenteric artery will be eventually drained, the lymph will be eventually drained to the superior mesenteric lymph nodes, the blue ones, these ones, superior mesenteric lymph nodes, and the parts which are supplied by the inferior mesenteric artery, the lymph from these parts will be eventually drained into the inferior mesenteric lymph nodes around the origin of the inferior mesenteric artery. Now don't worry about these, the left colic, right colic, middle colic, so they are correspond to the arteries. So you just need to know that the only focus on these main ones, superior mesenteric lymph nodes and inferior mesenteric lymph nodes. Nerve supply, it's all autonomic and comes from the plexuses, and you should now again think of the arteries also. So there is a plexus around the celiac, around the superior mesenteric artery, we call the superior mesenteric plexus. There is a plexus around the inferior mesenteric artery, we call it the inferior mesenteric plexus. The down parts which are in the pelvis will be supplied by another plexus, we call it inferior hypogastric plexus. So the parts which are supplied by the superior mesenteric plexus includes the
appendix, cecum, ascending colon, first 2/3 of transverse colon. The parts will be supplied by the inferior mesenteric plexus, includes the last third of transverse colon and descending colon, and the parts which are supplied by the inferior hypogastric plexus includes the sigmoid colon and going down with the rectum and anal canal. Rectum and anal canal we'll do in the next slides, but at this point sigmoid colon is supplied autonomically, including the sympathetic and parasympathetic, by the inferior hypogastric plexus. Now let's move to the rectum. Again, the same images that I used in the slides of the sigmoid, now I will use them again for the rectum. Now this is the rectum, starts from S3 and ends at the pelvic diaphragm down there, where it continues with the anal canal. So it's about 13 centimeters long. Anal canal will be only the last 4 centimeters, and the rest is rectum. How it is related to the peritoneum. Now this is the peritoneum, that's the blue shading, that's the peritoneum. And for simplicity, you just need to divide the rectum into 3/3, the upper third, the middle third, and the lower third. So on this image, maybe the middle third looks a little bit smaller, but don't worry, this is it is still good for the presentation and explanation. Now, the upper third is covered by peritoneum anteriorly and on the lateral side. So on the anterior side and on the lateral sides, on the right and left, it's covered by peritoneum. The middle third only covered by peritoneum on the anterior side. The lower third has no peritoneum. It's completely extraperitoneal. Again, upper third covered by peritoneum anteriorly and laterally on both right and left side. Middle third only anteriorly. Lower third has no peritoneum. What about the relations? So these are the relations of the rectum in female, and these are the relations of the rectum in the female. Let's start with the male. So this, what is anterior to the rectum? Sigmoid colon, in male and in female. If we go more inferiorly, so in the male there will be the urinary bladder with the seminal vesicles and end of vas deferens. If we go even more down, it will be related to the prostate. So prostate, seminal vesicle, vas deferens, and the bladder, they are anteriorly related to the rectum in males. In females, it's the vagina, the posterior surface of the vagina, including and then you should also include the sigmoid colon. Now you should also be aware of these pouches. In the female, this is the recto-uterine pouch where the sigmoid is located. Now if you continue, you will see another pouch which is called the uterovesical pouch between the uterus and the urinary bladder. So these are peritoneal pouches. In male, there is only one pouch, which is the rectovesical pouch, the rectovesical pouch. What about the posterior relations? So posterior relations of the rectum, now you can see only on this image the sacrum, but there are other things added to it, and this will be covered in the next slide. This is a very good image showing you the posterior relations of the rectum. So that's the rectum, and these are the posterior relations. What are the structures that you find posterior to the rectum apart from the sacrum? So sacrum is this one, and then you will see two muscles. One of them is the piriformis, and the other one is the coccygeus or ischio-coccygeus. So this is part of the pelvic diaphragm, but it's not part of levator ani. We call it coccygeus. So two muscles, and also these structures which are the parts of the sacral plexus. There is also the sympathetic chain. So these are all posterior relations of the rectum. So including the sacrum, the sacral plexus, sympathetic chain, and the two muscles which are the piriformis and the coccygeus. Now there is a midline structure which you don't see on this image, but you see on that image, and that's an artery. We call it the median sacral artery. So this is an branch of the posterior side of the abdominal aorta, descends in the midline, anterior to the sacrum, posterior to the rectum. So these are the anterior and these are the posterior relations of the rectum. Now let's focus a little bit on the features of the rectum. So that's the rectum, starting from the rectosigmoidal junction and ending at the anorectal junction. So that's the rectum. Internally you will see transverse folds, 3 of the transverse folds, 2 of them on the now this is a posterior view, so this is the right side, this is the left side. So 2 of them on the right side, 1 of them on the left side. So these are the folds. It still has inner circular, outer longitudinal layers of smooth muscle within its walls. The lower end of the rectum is distended, and that's called the ampulla of the rectum, okay, which is that one. So this is the end is distended. We call it the ampulla of the rectum. So internally you will see the folds. Externally you will see these flexure, lateral flexures. So externally you will see the flexures. If you internally you will see the mucosal folds. One thing also to note about the anorectal junction, that it's not a vertical junction, but it's a little bit pulled anteriorly by this muscle, which is part of the levator ani. We call it puborectalis. So it pulls the junction anteriorly, so that's why there is an anorectal angle about 80 degrees. Okay, so this also helps in the continence of the rectum. So it's found at the rectal angle. We call it perennial flexure because this is almost inside the towards the perineum, and that's why it's called perennial flexure. One thing also to note about the rectum, there is no tinea coli. There is no tinea coli. So this is one thing. I already mentioned that the transition from sigmoid colon to rectum starts at the level of S3. So the best way to find it is to follow the tinea coli of the sigmoid colon downward until it disappears. So when you do this, follow the tinea coli of the sigmoid colon downward towards the rectum, the point where the tinea coli disappear, so that's the point of the rectosigmoidal junction, the end of sigmoid and the beginning of rectum. Blood supply of the rectum and lymph drainage of the rectum. Now, in one of the previous slides I mentioned that it will make it very easy or easier for you to divide the rectum into 3/3, and this is very relevant when it comes to the lymphatic drainage and blood supply. So the rectum has 3
arteries. It has a superior rectal artery, a middle rectal artery, and an inferior rectal artery. And these arteries, they have different sources. So the superior rectal artery is a branch from the artery of the hindgut, which is inferior mesenteric artery. So inferior mesenteric artery will give the superior rectal artery. Middle rectal artery and inferior rectal arteries, these are coming from the internal iliac artery. Middle rectal artery is a direct branch of the internal iliac artery, while the inferior rectal artery is a branch of one of the branches of the internal iliac artery, and that branch is called the internal pudendal artery. So internal pudendal artery will give one branch, and that would give, which gives a branch that's called the inferior rectal artery. So superior rectal artery from inferior mesenteric, middle rectal artery from internal iliac artery, inferior rectal artery from internal pudendal artery, which is itself a branch of the internal iliac artery. When you come to the veins, it's again the corresponding vein. So we have a superior rectal vein that will drain into inferior mesenteric vein. Middle rectal vein will drain into internal iliac artery, internal iliac vein, sorry, and inferior rectal vein will drain into internal pudendal vein. So 3 veins, 3 arteries. Now, when we come to the lymphatics, again think of the arteries. Superior half of the rectum, the lymphatics will drain into the inferior mesenteric lymph nodes. From the inferior half of the rectum, lymphatics will drain into the internal iliac lymph nodes. So inferior mesenteric lymph nodes and internal iliac lymph nodes. Don't worry about the other lymph nodes which are mentioned on this image. Only please focus on the highlighted ones. Nerve supply of the rectum, it's again autonomic, sympathetic and parasympathetic, and it comes from the inferior hypogastric plexus. Now, in the abdomen, we talked about celiac plexus, superior mesenteric plexus, and inferior mesenteric plexus. Now we are in the pelvic cavity. Now we should think of the other plexuses found over there, and those are the hypogastric plexuses. There's a superior one and there is an inferior one. If we talk about the rectum, so it's the inferior hypogastric plexus. Okay, now we talk about some clinical or applied anatomy related to the large intestine. Now, large intestine can have different diseases which produce different symptoms, and sometimes it's very hard to diagnose these diseases without having a look what is inside. And that's why one of the investigation that can be done to visualize inside the colon is called colonoscopy. So when there is a scope is in a colonoscope is inserted through the anus into different parts of the colon, and then the physician or the doctor can have a look at what is inside. And then on this image you can see a lot of diseases that can happen in the colon. Some of them are inflammations like ulcerative colitis or Crohn's disease. Some of them like polyps or these appendages inside the colon. If they are not treated or not excised, they can turn into tumors, sometimes tumors, so or cancers. So a lot of diseases that can be visualized by
the colonoscopy. So this is one of the important investigation that can be done, and the knowledge of these curvatures or these turning points between different parts of the colon is important to just guide the scope inside the lower gastrointestinal tract. One of the conditions that can also happen in the colon is the formation of diverticula, and that condition is called diverticulosis. And if these diverticula get inflamed, though, it's called diverticulitis. These diverticula are just bulging of the wall of the large intestine, and it happens in the places where there is no Taenia coli. So in a previous slide you saw something like this. So that's Taenia coli, and in this area you only find circular smooth muscle, and in some places this circular smooth muscle becomes weak, especially where the blood vessels enter into the wall, and this will lead to the bulging of the wall, and this bulging is called diverticula. So these diverticula, if not treated, they can perforate and then can cause leakage of material into the abdominal and peritoneal cavity. So this is one of the conditions. The other condition can happen in the large intestine, is called a volvulus. A volvulus happens in parts of the intestine that have a mesentery. So it does not happen in retroperitoneal parts, but happens in the intraperitoneal parts. One of them is the cecum, so it can happen in the cecum, and it can also happen in the sigmoid colon, which is turning of the or twisting of the sigmoid colon. So instead of being continuous tube, it gets twisted, and the point of twisting, the colon becomes blocked, so nothing enters into it, nothing comes out of it. This will cause intestinal obstruction, distension, inflammation. It can also lead to gangrene, and it can also lead to perforation if not treated. So this is an image of a huge sigmoid volvulus. So you can see how big it becomes if not treated on time. One of the causes of intestinal obstructions is also is termed intussusception. So this happens when one part of the intestine gets telescoped, which means it enters into the other part. So it's one part actually, but a segment of it enters into the other segment, and it continues until the one which is inside gets blocked. So this is one of the causes of intestinal obstruction. So in this case it can happen between the ileum gets inside the cecum. We call it ileocecal intussusception. It can also happen only in the small intestine alone, parts of the ileum. So this is ileoileal intussusception, and this is how it looks. And for treatment you just need to pull the two parts apart, and then the lumen gets continuous again. One of the procedures or operations that can also happen in the colon is called colostomy, which is an opening of the colon to the anterior abdominal wall. So this happens, for example, in this case, if there is a tumor in this rectum or tumor part of the sigmoid colon, and this part has to be removed, and there is no way to connect the rest of the colon to the rectum and anal canal. The only option is to connect the colon to the anterior abdominal wall, and then the feces will come out through the anterior abdominal wall, but then it will be attached to a pouch or a bag where the material will be collected continuously into these bags and then discarded. So these are some of the applied anatomy that you should have a knowledge about at this point.
Now let's move to the anal canal. So anal canal, I told you, so it's after the anorectal junction. It's found mostly in the perineum, so that's why it should be included in the perineal, not the pelvic cavity. But now, because now we are doing the tract, we will put all the parts together, because this is almost like a systemic approach, not a regional approach. It's about 4 centimeters, and the important relations are the following. So if again it's male and female, when we talk about posterior relations, there is no difference in males or females. There is a collection of fibrous tissue between the coccyx and the anus. It's called the anococcygeal body. It's found posterior to the anal canal in male, and it's also found in posterior to the anal canal in females. The difference comes in part of the anterior relations. So if we think of anterior relations, there is another fibrous mass anterior to the anal canal in males and in female, and that is called the perineal body. So it's found in males and females. Urogenital diaphragm is also anterior to the anal canal. It's also found in male and female. The difference comes is in the content of the urogenital diaphragm. In male, it's the membranous urethra. In female, it's part of the vagina. There is also the bulb of the penis in males anterior to the perineal body. So posterior relations are the same, anterior relations, most of them are the same, but you need to think of the reproductive structures in male and female. Laterally, this image shows you the lateral relation. So the bigger images showed you the anterior and posterior relations. This image shows you the lateral relation of the perineal or the anal canal, and this is called the ischiorectal fossa. So this is the ischium, the part of the hip bone, and that's the rectum. So this space is called the ischiorectal fossa, which includes a lot of fat and other structures that you will do when you do the perineal lecture. Internal features of the anal canal. Now this is the anal canal. So you remember the puborectalis is the part of the pelvic or the pelvic diaphragm or levator ani that demarcates the ano or rectoanal junction. So from that point going down, that's the anal canal. In the upper part you see different structures. So you see these mucosal folds that we call them the anal columns, and as you can see, the anal columns will end down in these inverted arches that are called the anal valves. So that's the valves. Okay, so these are the anal valve, and that's the columns, and that space which is bounded by the columns and the valve called the anal sinus. So anal columns, anal sinus, and anal valve. Now the valves, there is a line that we call the pectinate line. This pectinate line, which is demarcated by the valves, is very important because it's the point where the anal canal is divided into upper part and lower part. And this is important, as you will see later, in terms of blood supplies, lymphatic drainage, nerve supplies, and there are a lot of differences between this part of anal canal, which is above the pectinate line, and this part of anal canal, which is below the pectinate line. One thing also that you can see on this image is these are the sphincters. So there are two sphincters controlling the passage of feces out of the anal canal, and there is an internal one, internal anal sphincter, and there is an external one. So the internal anal sphincter is just the thickening of the inner circular smooth muscle of the anal canal. It is involuntary and it's made of smooth muscle. On the other side, on the other hand, the external anal sphincter is much stronger. It's made of skeletal muscle and it is voluntary. It has three parts. There is a subcutaneous part, a superficial part, and a deep part. And the deep part attaches or connects with the levator ani. Okay, so three parts. The differences are, again, this is internal anal sphincter is made of smooth muscle. It's involuntary, supplied by autonomic nerves from the inferior hypogastric plexus. The external one is voluntary, made of skeletal muscle, supplied by somatic nerve fibers coming from the inferior rectal nerve and the fourth sacral spinal nerve. So these are the main differences between internal and external anal sphincters. Now, what are the differences between the upper half and lower half of anal canal? They differ in so many things. They differ in their embryological origin, and they differ in their epithelial lining, arterial supply, venous drainage, lymphatic drainage, and nerve supplies. These two images summarize everything. Now, when we come to the origin, the upper half is endodermal origin, while the lower half is ectodermal. So this is endo, not into. Endodermal. The upper half is lined by simple columnar epithelium, like the most of the rest of the parts of the gastrointestinal tract. The lower half is lined by stratified squamous epithelium. It starts first as non-keratinized and it ends as keratinized, where it continues with the skin. Regarding the nerve supply, the upper half is supplied by autonomic nerve fibers from the inferior hypogastric plexus, while the lower half is supplied by somatic nerves, not autonomic nerves. Somatic nerve fibers from the inferior rectal nerve. When we come to the blood supply, the upper half is supplied by branches coming from the superior rectal artery, while the lower half is supplied by the branches coming from the inferior rectal artery. Now, please remember that the demarcation between upper half and lower half is the pectinate lines towards the anal valves. Lymphatics will follow arteries, so lymphatics from the upper half will end up into the inferior mesenteric lymph nodes, because they follow the superior rectal artery, while the lymph from the lower half drains into the superficial inguinal lymph nodes. So that's a summary of the differences between the upper half and the lower half of the anal canal. Applied anatomy of rectum and anal canal. Now this relates to the relations. So there are, I mentioned the relations and I stressed the relations. Now, you know, in males the prostate is anterior to the rectum, and this can be utilized clinically by a procedure called perirectal examination. So this is if the doctor wants to examine the prostate of a patient, so inserting a finger through the anal canal into the rectum and then feeling the prostate, for example, feeling the size of the prostate, the texture of the prostate, the if the patient feels pain. So this is called perirectal examination. It's done because the prostate is anterior to the rectum in males. In females, there is another procedure that can also be done. It's called rectovaginal examination. This is for examining the uterus. So it can be done only by vaginal examination, but in some cases where only vaginal examination cannot give all the information, so the option is rectovaginal examination, where one finger is inserted into the vagina and the other one is inserted into the rectum. So this can be done because the vagina is one of the anterior relations of the rectum in females. What can also happen is a case called rectal prolapse. So this is a normal rectum when the pelvic diaphragm is intact. It's strong and it's preventing the rectum from falling down or bulging out of the anus. In some cases, because of the weakness of the levator ani or sphincters, part of the rectum can bulge out of the anus, and this case is called the rectal prolapse. So part of the rectum can come out of the anal canal. So this can be treated surgically just to restore it back, to restore the back to the normal condition. The last part of this lecture, 2 slides on the barium investigations of the gastrointestinal tract. Actually, these 2 slides were meant to be part of the first lecture, which is the upper gastrointestinal tract, but then I decided to move them to the end of this lecture instead of just mentioning them after the slide number 6, because it will also cover the lower gastrointestinal tract. So barium investigation, this is a type of X-ray, but it's a contrast X-ray, which means usually a plain X-ray will not show you a lot of details of the gastrointestinal tract. Now if you want to visualize more structures, to see more details about different parts of the gastrointestinal tract, so that's why the contrast is introduced into the different parts of the gastrointestinal tract. And this contrast will, when X-ray is taken, it will look radio opaque like this, so it will look white in comparison to the other soft tissues around it. And accordingly, these investigations will be given different names according to which part of gastrointestinal tract they visualize, or in which part of the gastrointestinal tract the contrast medium is introduced. Now this image showing you the one of these investigations, and it's called barium swallow. Why? Because it only shows the esophagus. So if it only shows the esophagus, so this procedure is called barium swallow. So while the patient is swallowing the liquid that contains the barium, the X-ray is taken, and this will show you the details of the esophagus. So that's the esophagus in the thoracic cavity. Now the second type is called barium meal. So barium meal, in comparison to the swallow, this is when the barium reaches the stomach. Now you can see the stomach. So this is the stomach. You can see the fundus of the stomach. You can see the greater curvature. You can see the lesser curvature. You can see the pylorus and the part also of the
duodenum, but it's not as clear as the stomach. So now the barium has reached the stomach. Now we call it barium meal. On this image, that you can see the stomach, but you also can see a big part of the small intestine. So that's the duodenum, and then you can see the jejunum. Now we don't call it swallow, we don't call it meal, but we call it barium follow through. The barium has reached the parts of the small intestine. One thing also to notice in the small intestine is this appearance. So this is very classical appearance of the small intestine in barium follow through. It looks feathery because of the plica circularis, or a lot of folds inside the small intestine. Now this is the barium follow through. Now this one is different because it shows the large intestine. So here you can see the sigmoid colon, you can see the ascending colon, the transverse colon, the descending colon, and the cecum. Now in the previous three images or investigations, the barium was introduced through the mouth. Now for this investigation, to visualize the large intestine, the barium is not introduced through the mouth, but it will be introduced through the anus. So it will be injected through the anus, and then it moves up and fills the different parts of the large intestine. Now this investigation is called barium enema. So when the barium medium is introduced into the large intestine through the anus, now this investigation is called barium enema. And then you can see the hostria very clearly, and it's very different from the small intestine. Here you see the feathery appearance because of the folds. Now in this one you don't see the same appearance, but you see the hostria. So these are the different barium investigations showing different parts of the gastrointestinal tract. Now this is the last lecture. This is the last slide of the last lecture of the gastrointestinal tract. Now the lecture should be 50 minutes, but I included more material because in this course there is no practicals. Usually in a normal condition we give you a 50 minutes lecture, and then in the practical we teach more. We still explain a lot of things in the practicals in those 2 hours practical. Now you don't have practicals in the lab, you only have those short videos on some structures from the lab. That's why I decided to put more slides, to do more explanations in the lectures, to make sure that you really get a good grasp of the content of these 3 lectures. They might be long lectures, but you don't have to do it in one go, so you can break the lecture into different parts. Maybe you can divide it into 2 or 3 parts, you take breaks or whatever. That's the end of my part in the structure function relationship course, and if you have any questions, please don't hesitate to email me your questions anytime. And I still have one video on the on the practical of the posterior abdominal wall that will be uploaded very shortly, inshallah. Thank you again. Assalamu alaikum wa rahmatullahi wa barakatuh.